How's the sound for everyone there?
Good.
Great. Hello, welcome back to our 5th fictional COVID case. So this session is for all our junior doctors, staff grades and consultants to learn and share experience of managing coronavirus in mental health settings. Again, we're welcoming colleagues from across London and from Norfolk and Suffolk. Slides for the previous 4 cases are freely available, and ELFT doctors can also access the full recordings of each session. It's another brilliant case this week. Thanks to our expert reviewers, Olivia, Protti and Tara Lawn, for all your help and advice. It's the same format, so please do add your comments in the chat box. Remember to share your comments with all attendees if you want everyone to see them. We really do value your input into the cases, and the questions that you raise each week are incredibly important. Again, huge thanks to our researchers and presenters, Cate and Lynsey McApline, for producing these amazing cases each week. It's a huge amount of work from these two to bring the session, so thank you both.
All right, hi everyone, and welcome back to week 5. Yeah, can you believe it's been 5 weeks already?
No, we didn't rehearse this though. we're doing like banter now.
No, I'm just sorry guys. I'm post nights at the moment, and I'm a little bit high energy. I'll probably crash about halfway through, but we'll see how it goes. All right, so week 5. I think we'll start with our usual reminder that things are changing very rapidly. We are putting links to all the guidelines at the end of the case, and do keep an eye on them because they are getting updated quite frequently. All right, do you want to talk about PPE updates?
I love talking about PPE updates. PPE date. Yeah, that didn't work, sorry. So basically, we've had the Resuscitation Council on the 15th of April kind of make a statement saying what we said already, and we stand by that. And essentially, they're still saying that people need level 3 PPE, so that's aerosol generating the kind of PPE that you wear when there's aerosols around for any kind of resuscitation. But they're also saying that early application of the defibrillator while other people are putting on their level 3 PPE is the way to go. And we've also had, should we go to the next slide? So version 2 standard operating procedure from ELFT in the last few days, basically giving us a nice flow chart on how to proceed if there's someone who's needing resuscitation. So again, it's kind of saying that you can kind of get the defibrillation equipment ready and kind of going, but don't start CPR or any other resuscitation without wearing aerosol generating PPE. So some clarity there for us this week.
All right, so let's get started with this week's case then. So this week we're the SHO on call, and we've been asked to see Mrs. T, who's a 36-year-old lady who's currently in A&E, having been brought in by her partner. So she's gravid 3 para 1 and at 34 weeks gestation, and the A&E team have reviewed her and said they don't have any concerns about obstetric issues. She's not got any significant past medical history, and we get an initial set of OBS from the nursing staff at A&E, which don't look particularly concerning. The A&E team hand over that she's anxious, she's agitated, and she's very, very distressed. She's been saying that she wants to leave the department, but her partner's been trying to calm her down and trying to convince her to stay in A&E for long enough to see a doctor. So you have a quick look at her notes before you go and see her, and you see that 12 years ago she had some CBT for OCD symptoms, which worked very well, and she never ended up under mental health services for that. And then 6 years ago she was admitted under the Mental Health Act for treatment of a postnatal psychotic episode that happened 3 weeks after the birth of her son. And during that episode she was quite risky, so she was doing things like jumping off a first floor balcony whilst holding her baby. She was treated with olanzapine at the time and stayed on that for a year, and was, that was successful treatment. She did quite well on that. And you see that her son, who's now 6 years old, was on a child protection plan for 8 months, but that was closed to social services after the psychotic episode resolved. And then during this pregnancy, the GP very appropriately referred her on to perinatal mental health services given her risk of previous episodes. And she's been to 2 appointments so far with the team. At both appointments she presented as completely well, with no evidence of any psychotic phenomenon. And during those discussions with the perinatal team, she was considering the possibility of a prophylactic admission to the MBU when she was closer to term, just because she's such a high risk of having a relapse. And she had agreed with the perinatal team that if she was to deteriorate, her first choice would be to restart olanzapine if she was having any concerning symptoms. So what are your thoughts going into this assessment? What are the sort of things that you're going to be looking for when you talk to this patient? I'll give you a second to give us some thoughts.
So we've got a comment of old SS. What does that stand for?
I don't know what that means.
So we want to, okay, so old previous symptoms and current symptoms, assessing her current mental state, looking at her current support system, looking for relapse of psychotic illness. A good point about asking about her ideas about COVID, because people are holding kind of fear and may not kind of talk about this unless they're directly asked. Getting some history from the husband about what his concerns are. Looking at whether she's got any other family history or medical comorbidities. Oh, thank you, Nick. Signs and symptoms. Cool. Excellent.
All right, so some good suggestions there. And I think people are quite rightly saying that this is someone who's very, very high risk of a relapse of her psychotic presentation. And as such, we're going to be quite concerned going in. We're going to need to get quite a lot of detailed information about her mental state. And I think a good point as well about exploring what her husband's concerns are. All right, so you go along and you start by speaking to her husband in A&E, who tells you that she's been increasingly anxious since the government lockdown started. But in the last 24 hours, she's been much more out of character, so very irritable, pacing the flat, getting really preoccupied with worries about catching coronavirus. She's also been trying to sterilize everything in the flat, and she only slept for 3 or 4 hours last night. And then when her partner tried to take their 6-year-old out for a walk to get him out of the house in the morning, she started screaming at him in a way that was very, very out of character. So that was his concerns. You also get some collateral that she's been furloughed from her job, so she's currently on 80% of her normal salary, and she's worried she might lose her job in the near future. And her partner has lost his job because of the pandemic, and so he's at home all day, their son's at home all day because schools are closed, and they're living in a really small flat together. She was also due to have a routine antenatal appointment yesterday, and that was one that had been due a few weeks previously but had been rescheduled because of the pandemic. And she was supposed to dial in for that appointment, but because of difficulties with the phone signal, she couldn't dial in. So that was really quite distressing for her. We take a quick obstetric history. So we see that her first pregnancy when she was 30 was planned with a normal delivery at term. She obviously had the psychotic episode that we've talked about already. And the 6-year-old son is at home with his paternal grandmother this afternoon while they're in A&E. She also had a second pregnancy 2 years ago, which was also planned, but which miscarried at 19 weeks. And then this pregnancy, she's currently at 34 weeks, and it was an unplanned pregnancy, and she's not had any complications to date. All right, so you do a bit of a mental state assessment, and you see that she's very tearful, she's very distressed and anxious, and she's pacing about. But as you talk to her, she becomes less distressed, and she is able to engage quite well with the assessment. She's talking quite rapidly, and she's saying subjectively and objectively she looks very anxious, and she says she feels really overwhelmed with her worries about coronavirus. But you don't get the impression that there's any significant mood symptoms there, and she's got a reactive affect. There's no formal thought disorder. She's quite preoccupied with coronavirus and the potential implications this might have for her pregnancy. But when you challenge and sort of explore those delusions, you don't see any evidence that there's a delusional intensity to it. And you also try and explore whether there's any obsessions and compulsions, and you don't see any evidence of that either. There's no hallucinatory phenomenon. She's completely oriented. And she does, as you talk to her, she does seem to have quite good insight. She does agree that she needs help with her mental health. She does think that the pandemic has been incredibly stressful, but she's quite clear that she doesn't want to come into hospital and she doesn't want to take any medication just yet. So what are your initial thoughts then about this lady?
So some thoughts about risk. What what is the risk, and do people have thoughts about how we would then assess that or get an idea about her risk? Some other ideas about more collateral from the partner, thinking about HTT.
Some some comments about how her fears are quite understandable given the previous miscarriage.
So some discussions about HTT, whether or not people think HTT should be involved.
Yeah. People pointing out that she is already under perinatal, so it might be helpful to liaise with them. Okay, so let's see. Yeah, so exploring these risks in a bit more detail, it doesn't seem like there's any specific risks to either her existing child or to the pregnancy. Although she's distressed, she's not doing anything that's harming the kid. And I think that the main priority here is about managing her anxiety and her distress. We're going to take a quick look at the government guidance around pregnancy and coronavirus. So the government has categorised pregnant women as vulnerable and has really strongly advised that they follow social distancing, that they use remote access to the NHS, and that they work from home if at all possible. There's a lot of people with concerns around how coronavirus is going to affect their pregnancies. And what the Royal College of Obstetrics and Gynecology and the Royal College of Midwifery are saying is that so far we know that women who are pregnant don't seem to be at higher risk of contracting coronavirus. However, we do know that during pregnancy the immune response is altered, and so there's this potential risk, as with any other viral infection, that they might have more severe symptoms than someone who's not pregnant. And that's particularly at the end of the pregnancy that they have those concerns. We also know that vertical transmission is probable, but we don't know how many pregnancies are going to be affected by that, and we don't know what the implications are for the baby. We know that so far there's no evidence of teratogenicity, and so far there's no data to suggest that there's an increased risk of miscarriage or of early pregnancy loss. I think pretty much every organisation that's involved in looking after pregnant women is in consensus here that pregnant women need at least as much support, advice, care and guidance in relation to the pregnancy, childbirth and early parenthood as before the pandemic. And I think that's really important to bear in mind, given that we're very worried about social distancing and keeping people out of hospital, but actually this is a very vulnerable time for people, not just for the mental health, but for physical health as well. And so we have to make sure that we're offering as much support as we would be in normal circumstances. So you have a discussion about this lady with the on-call SPR, and having gone back and forth and done a bit of a risk assessment, you agree that she doesn't meet criteria for detention under the Mental Health Act. She doesn't want to be admitted, but she is willing to work with home treatment team. She's got an appointment in 2 weeks' time with her perinatal team, so you make contact with them and let them know about the presentation to A&E and ask if they can move up that appointment and see her a bit sooner. And as they're about to leave A&E, her husband shows you the sort of cloth masks that they bought online and asks if they should be wearing these masks on their way home. What do you guys think about that?
So there's some no answers, yes answers, personal choice answers. Someone's mentioned precautionary principle, which of course is the paper that Tricia Greenhull had kind of written, recently, and it's been a kind of debated topic of late about whether we should all be wearing masks.
Yeah, so I mean, I suppose it is still a debated topic, and I think a lot of the concerns are that people using it in public will be taking away resources from healthcare professionals. But what Trish Greenhull and her colleagues are arguing, and I think this is one of the opinions that's quite widely accepted now, is that the use of cloth masks, so not fluid-resistant surgical masks, are totally appropriate in public places. So if you're going out to do your shopping and things like that, you should be wearing them. And their argument effectively, I mean, I'd encourage you to go and read this paper, it's a very good argument in favour of them, is that we don't really have enough scientific evidence to robustly say whether or not they help. but we're pretty confident that they don't do any harm, and there's a theoretical possibility that they are helpful. So they're advising that people do use the cloth masks when out in public.
And I think the only downside is that they've found that some people sort of adhere less to social distancing if they're wearing a mask, because there's this kind of false belief that you're more protected and that people aren't necessarily adhering to any of the other things like hand washing or that sort of thing. So pros and cons. But yeah, the masks themselves certainly aren't going to do any harm.
Yeah, absolutely.
Yeah.
So you can give that advice to your husband, say, knock yourself out, go for it. All right. So she's agreed to home treatment team, but I think we're all quite aware that home treatment team has really changed its practices recently, trying to minimise the number of face-to-face contacts unless they're absolutely necessary. Be interested to hear your thoughts about what sort of support home treatment team can offer and whether they should be doing home visits with this lady.
So some thoughts about phone contact. Can be daily phone contact and escalate to face-to-face if needed. So potentially a home visit with PPE and then phone contact after that.
Yeah, so I think in this case, video consults is another suggestion coming through. I think in this case, home treatment team's role is really to hold her and monitor and manage risk until she can see the perinatal team again. And so I think phone contact in this case is probably quite an appropriate starting point, with room to escalate to home visits if any concerns arise. Bearing in mind she does have her partner at home who does seem to be supportive and does seem to be willing to make contact with services if anything deteriorates.
And there's some comments about the fact that if there's not going to be face-to-face visits, that home treatment teams are offering perhaps more phone contact than they would otherwise as a kind of alternative. But also some home treatment teams are still doing kind of initial assessments face-to-face and then kind of taking it from there. So.
All right, so a few weeks later, you're talking through this case in supervision and you decide to have a quick look at her notes to see how she's been getting on. And you see that she's had a few phone check-ins with HTT, which seemed to go really well, and then made it to her perinatal appointment, which was moved up. So she's been in regular video contact with the perinatal team, and she started doing some weekly one-to-one sessions with the perinatal psychologist, starting to work on the anxiety symptoms, and that all seems to be going quite well as well. A month later, you are back on call again, and at handover, as you're starting your shift, you learn that Mrs. T is now 2 days post-C-section, and her mental health has deteriorated in the past 24 hours. The SPR, the outgoing SPR, has just come from doing a mental health act assessment on the labour ward and has put her on a section 2. And she's just arrived on the MBU as your shift starts, so you've been asked to go and clerk her in. So leads to an interesting question, actually. Should we be admitting COVID-19 patients to the mother and baby unit? No responses at all. Oh, here we go.
So some saying yes and then isolate. So essentially if you can isolate then yes, or reverse barrier nurse. And discussion with the specific MBU to find out if they're what isolation facilities they have.
Fair enough. So the COVID guidance is quite clear. I don't know why that's come up like that, it's a typo. So we have to remember that maternal mental illness is one of the leading causes of maternal death, especially psychotic presentations. And that's why we're making the decision to admit someone to the mother and baby units, because of that significant risk. We also know that admitting a mum without the baby can lead to quite poor outcomes in the longer terms in terms of bonding and feeding. And so in cases like this, I think the consensus is that the benefits of joint admission outweigh the risks. All right, so before going to see her, you take a quick look at her obstetric notes and you see that they did COVID screening as she arrived on the labour ward. When she arrived there, she'd had a 2-day history of a persistent cough and an upper respiratory tract sort of symptom. She had a borderline raised temperature, so right on 38.0. Her sepsis screen was negative and they sent a COVID-19 swab. They isolated her on the ward as suspected COVID, and she ended up having an unplanned C-section because the baby was breech. After delivery, the obstetrics team tried to nurse her in isolation. However, they were finding that quite difficult because her mental state deteriorated quite quickly after the C-section. So she's been quite agitated, she's been very distressed, and she's been refusing all of her medication, including the analgesia prescribed after her C-section. All right, so you're about to go and see this lady. Just a quick reminder, I know we talk about it a lot, but safe PPE. So this is not an aerosol generating procedure. You're just going to clark her in. So it will just be the standard surgical mask, apron, gloves, and I suppose you can make a decision about eye protection as well. All right, so you get to the ward and you realise that she's just smashed her phone on the ground, and she tells you that she did this because the government's using the 5G network to spread coronavirus. She's also concerned that the government's hacking into her thoughts. She's very fearful, she's very suspicious of staff. But you do observe that she's holding the baby safely, so there's no immediate concerns that she's going to harm him. But she's not attending to his needs very well, so when he starts crying, she doesn't immediately respond to that and notice that he's hungry and needs to be fed. She doesn't have any thoughts about harming her baby, but she's really concerned that the government might try to infect him with coronavirus. She is oriented to time, place and person, and although she's quite suspicious of staff, she does recognise one of the nursery nurses from a previous admission, and she appears to be more trusting of that particular staff member. Okay, so you do a physical examination. You see that she's still coughing, and the staff have given her a face mask to wear, but she is taking it off at times because she's finding it quite annoying. She's also complaining of some muscle aches, some headaches, and a sore throat. Physical examination doesn't show anything really significant. Her C-section scar is healing well, and at this point her OBS are all pretty stable. She doesn't want an ECG, but her one done 2 days ago was absolutely fine. And she refused blood tests, but she did have routine bloods when she was admitted to obstetrics, and they were fine as well. And you also chase up the COVID-19 swab results that were sent 2 days ago, and you see that she has a positive result. So what's your working diagnosis at this point, and what are your thoughts about this lady?
Is it like the network connection, or is it tumbleweeds? I don't know. Okay, so some thoughts about postpartum psychosis and COVID.
Is there anything else on your differential list?
So one idea about bipolar and a thought about delirium as a differential.
Fair enough. So I think psychosis is at the top of my list of differentials, partly based on her presentation and also based on her history. But we do have to consider the possibility that she's delirious, and that could be secondary to COVID. It could also be secondary to pain because she's been refusing all of her analgesia. We did check the C-section scar and didn't see any evidence of infection there, so we're not as concerned about that right now, but worth keeping an eye on. All right, so what kind of management plan are you guys coming up with? What do you think we should be doing with this lady? So some questions about bonding and breastfeeding.
Mm-hmm.
A question earlier, or a sort of comment about whether baby has coronavirus as well. So we did talk a little bit about the theoretical possibility of vertical transmission.
Mm-hmm. So some ideas about one-to-one nursing, restarting olanzapine or whatever she'd responded to previously well, which was olanzapine. So generally the thoughts are she does need an antipsychotic. Some psychology, and isolate on the ward together.
All right, so let's talk through the plan in points. So we're going to put this lady on one-to-one nursing. I think we can probably agree that a new admission who's as distressed as this and postpartum probably needs to be on one-to-one. So you discuss that with the nursing team and they're on board with that level of OBS. You think about her physical health, so you advise the nurses to do QDS physical OBS, and in particular to be looking out for low SATs or a high rest rate, and encourage them to get in touch with the duty doctor if they've got any concerns. And as per most of the guidance, you're going to isolate her in her room or in a segregated section of the mother and baby unit, keeping her separate from any other patients. So she agrees to start some olanzapine. We know that she's done well on that before, and that was her preference when she was well, that she would be started on olanzapine. And she also agrees to take a stat dose of promethazine, which should hopefully help a bit with the distress and the agitation right now. And you prescribe some lorazepam and some promethazine as rapid tranq as well. You do have a discussion with the nurses about using the rapid tranq, and you point out that benzos should only really be used on a sort of risk-benefit basis because of the theoretical risk of respiratory depression. And you also prescribe her paracetamol, dihydrocodeine, and her low molecular weight heparin as per the obstetrics advice. All right, baby obs. So this is not consistent across all mother and baby units. This is the baby obs levels that we use locally. But we use a traffic light system. Based on this traffic light system, what level of obs would you put baby on right now?
So some red, orange, red, orange. That was nice. Red, orange, red, orange.
Okay, fair enough. I think with a brand new admission with these level of risk, given that we know she was quite risky during her previous pregnancy, I think to start off with, we'd have her on a red level of obs. This is something that would be done in discussion with the whole MDT. So you'd be having a conversation with the nurses and the nursery nurses overnight, and then the day team would review it to reconsider whether red was the appropriate level of baby obs. Yeah, so that's very much an MDT decision. We also have to have a chat about baby's physical health. So the recommendation from the Royal College of Child and Paediatric Health, I think is that what RCPH?
Yeah.
I forget. So they're recommending that you don't try and test the baby for COVID-19 because nasal swabs are really difficult to carry out in infants, and there's a really high rate of false negatives. The evidence so far suggests that COVID-19 is very, very mild in healthy babies, and we know that this baby doesn't have any complications neonatally. The recommendation is that healthy infants born to COVID-positive mothers should remain with their mother, and they're saying that the routine precautionary separation of a woman and a baby is not recommended because of the impact on feeding and bonding. All right, feeding then. So there's no evidence that COVID-19 is transmitted via breast milk, although it's acknowledged that there's very, very limited data on that so far, so that may change. The main risk with feeding is the risk of droplet spread because of the close proximity between mother and baby during feeding. But the recommended precautions are just pretty common sense things really. So washing hands before touching baby or any sort of feeding equipment, wearing fluid resistant surgical face mask while feeding, and sticking with sterilising breast pumps and bottles very strictly. All right. Visitors is another thing that will come up in this management plan because partner is going to be very keen to come and see his partner and his newborn. The national guidance recommends that we should limit visits to partners, co-parents and significant carers, but locally we're recommending no visitors to the mother and baby unit at the moment. So with Mrs. T's permission, you get in touch with her partner and update her about him about the admission, and also let him know about the no visitors policy. All right, so the next night, you're still on nights at this point, and you're called to see Mrs. T urgently, and over the phone the nurse tells you that she's become really breathless in the last hour, and she's got to the point now where she can't talk in sentences, she's very pale, and they've just done a set of obs that were quite concerning. So if we have a look at this on the news chart, we can see that there's quite concerning things there. Her rest rate is very, very high. She's desaturating. And her blood pressure is beginning to drop as well. So this is something that needs a very urgent response. So what do you do?
Do you want to flip back to the obs?
Oh yeah,
just so
sure.
people can see? Yeah,
There you go.
Yeah, we go. So people are saying medical admission, oxygen transfer to A&E, generally agreeing that and need to give her some oxygen and call for some kind of help. So maybe ambulance or medical SPR. Of course, that kind of varies where you are, whether you've got a medical response team that can come or whether you need to call an ambulance. But so lots of ideas about high flow oxygen and liaising with the medical team.
Yeah, absolutely. So you, on the phone to the nurses, you ask them to immediately hang up and call 2222 or 999, depending on what arrangements you've got locally, and they have to tell the operator that the patient is confirmed coronavirus, so that the response team are adequately prepared. You also ask the nurses to take the crash trolley to the patient's room and to start oxygen immediately. You also ask them to take the baby out of the room and put the baby in the care of the nursery nurses while the patient's deteriorating. And of course, this is one of those situations where you drop exactly what you're doing and just go straight to the mother and baby unit and get your PPE on. I think thinking about liaising with medics, this is a severely deteriorating patient. I think this is more of a crash call situation rather than a discuss with the medic situation at this point. And so, yeah, hopefully the crash team will arrive quite quickly to help out. Okay, so managing a deteriorating patient, we all know this. We all know to use an ABCDE approach. We all know that you treat the problems as you find them, and we have to reassess after every intervention that we do, and make use of every member of the team as effectively as you can. So you arrive on the ward and you see that she's very, very breathless and she's struggling to speak in sentences. She is still alert and she's able to tell you that she's having this stabbing chest pain, which is worse when she's trying to take deep breaths. What are the thoughts that are going through your head at this point?
So some thoughts about lots of votes for PE, very good, or an infarction of some kind. COVID, yeah, COVID. We definitely know she's got COVID, so could be COVID. An anaphylactic reaction, pericarditis.
Anything else that can cause breathlessness in a lady that's postpartum? Myocarditis is a good suggestion.
Mm-hmm. Amniotic fluid embolism is the one that's unique to women who've recently given birth.
Yep.
Question of whether it's too late for that. I think that is usually in the first couple of hours, isn't it?
Yeah, so it's actually a bit on the late side.
Very unlikely, but still worth being aware of had she been transferred sooner. Pneumonia, yeah, definitely. Some kind of bleeding. So is she bleeding from kind of C-section somewhere or something gynae?
Sure. Yeah. So this is not an exhaustive list, but this is the ones that I'd be concerned about. So we know she's COVID positive. We know that COVID causes ARDS. We also know that sepsis is very, very common postpartum and often overlooked. And many of you have already suggested PE and amniotic fluid embolisms. And of course, she's just had a C-section, so hemorrhage is a possibility. And postpartum cardiomyopathy is also a cause of an acute heart failure. After giving birth. All right, so we go straight into our ABCDE approach and we start with airway. The questions you should be asking here is whether or not she's able to talk, is she cyanosed, and are there any signs of airway compromise? And in this case, we know that Mrs. T is talking in sentences, so her airway is still intact. And so you move on to the next part of the assessment. All right, breathing next. So look, listen and feel for general signs of respiratory distress. We've already got the respiratory rate, but we're going to be keeping a close eye on that. And we're looking at the depth of each breath, the pattern of respirations, and whether chest expansion is equal on both sides. Looking at JVP, monitoring oxygen pretty much continuously at this point. And of course, we should be giving oxygen to all critically ill patients. And this patient should already be on oxygen as you ask the nurses to start that before you arrived. Okay. So we move on to the next part of the assessment. We're going to check her cap refill, her pulses, and the temperature of the peripheries, and we're going to keep her blood pressure cuff on so that we can repeat the BP measurements. You've also got to look for any external or concealed hemorrhage, so you're going to do an abdominal exam because that's the most likely source of any hemorrhage at this point. And if there is evidence of hypovolemia, and there is in this case because her blood pressure is dropping, then you would want to think about whether you're in a setting where you can cannulate and give 500 mils of sodium chloride or some crystalloid very quickly. That is, of course, going to depend on what you've got available locally. And if you are cannulating, then use the biggest cannula you can and take some bloods for routine hematological, biochemical, etc. And if possible, you're going to do a 12-lead ECG as well. So in this case, we managed to get an ECG off Our Lady. Any thoughts on this? So I'm not going to spend too much time discussing the ECG, but I suppose the main things to note is that she's obviously sinus tachy, and we can see some evidence that she's got a right bundle branch block in V1, V2, V3, and also some T-wave inversion in those leads as well. Does that make you think of anything in particular? So it's evidence of right-sided heart strain, isn't it? Just to be clear, you can't make a diagnosis, especially in an acute situation like this, based off the ECG alone. It's something that helps guide your thoughts and your management, and it does point us in the direction of a non-COVID cause of her breathlessness, but certainly not diagnostic at this point. All right, so we move on to disability. So we go back over A, B, and C to check whether any of the interventions that we've already done have worked. We check her drug chart, we examine her pupils, PF, check her blood glucose as well. So we see that her level of consciousness has deteriorated a little bit. So she's not fully awake at this point, but she's still responding to verbal stimuli. Her pupils are normal size, eco-reactive, and her stats have improved a little bit since you started the oxygen. You check her drug chart and you see that she's refused her heparin and her analgesia, and she's not had any benzos administered in the past 24 hours, and her BM is in normal range.
So just a question about whether or not COVID causes ECG changes. Does anyone have any thoughts on that? I guess I mean, a tachycardia would be one thing, but yeah. I don't think there's anything specific unless you've got other electric abnormalities.
There was certainly nothing on the MJ best practice when I checked it yesterday.
Yeah.
On ECG changes.
Yeah.
All right, so moving on, we do the next stage is exposure. And in this case, we're looking for rashes, bruising, phlebitis, checking her calf, and looking at the C-section scar in particular for any evidence of bleeding or infection. So C-section wound looks well, but you see that her left calf is red and swollen. All right, so you try and ask her about this swollen calf and what's going on there, but as you start speaking to her, her consciousness level deteriorates and she becomes completely unresponsive. There's no respiratory effort and you can't find a pulse. What do you do? All right, so just a reminder that we've already called 2222 at this point. This has all happened in the couple of minutes since we've made that call, and hopefully they are on their way and should be there imminently.
So starting CPR, but some people have mentioned putting on level 3 PPE. Others mentioning putting on the defib. So yeah.
So I'm sure most of you have already seen this, and I think we did show this slide in a previous presentation. This is the latest from the Resus Council, and it will look a little bit different to the resuscitation guidelines that you're used to. So this is their recommendations for resuscitation during in a COVID suspected patient. So normally you would expect to go straight into CPR when we find someone that's got no pulse and no respiratory effort. But what they're recommending here is that we do a rhythm assessment and potentially defibrillate first before starting CPR. And that's to give other members of the team time to put on their level 3 PPE to get started with CPR. So while you're waiting on the crash team, who should be there any minute now, the recommendation would be to stick the defib pads on and assess the rhythm, and give the resus team a bit of time to get their PPE on to get started with CPR. All right, so the crash team arrives, thankfully, and they take over the resuscitation as you give a handover. She's in VF, so they give a shock and resume CPR, and then at 2 minutes they reassess rhythm and there's been return of spontaneous circulation. And the crash team starts the post-cardiac arrest treatment, which is just the usual stuff that you would always do post-arrest.
Just the usual stuff.
She does this stuff all the time.
Oh, yeah. All right, so there we go. I suppose one thing to think about at this point is that she's been moved off to a different ward. Baby is going to stay on the mother and baby unit, at least in the very short term, until something else can be arranged. And obviously, partner needs to be contacted to get an update on what's happened. All right, in her case, they start her on some anticoagulation, and a CTPA confirms that it was indeed a PE that caused the breathlessness in the first place. All right, so that's the end of the case, but we did want to just add on some additional notes about VTE prophylaxis in patients in general. So this is just from the NICE guidance pre-COVID, pointing out that all inpatients to our mental health unit should be assessed for risk of VTE and bleeding. And they recommend any standardised VTE risk assessment tool is fine to use. And if they've got a risk of VTE and it outweighs the risk of bleeding, then they recommend low molecular weight heparin in the first instance, or Fondaparinux if that's contraindicated. And then the idea is that we should continue prophylaxis until they're no longer at risk of a DVT or a PE. But what about in coronavirus? So a Dutch study looking at ITU patients showed that there were very high rates of thrombotic complications, even in people that were on thromboprophylaxis. Why do you think that is, Kate?
Well, why do people think that might be? What's going on? Is there a COVID specific thing that increases people's risk of thrombotic events? Yeah, immobility, immune complexes, changes in platelet levels. So we do see people with reduced platelets sometimes as well, don't we?
Yeah.
With COVID. So there's that side of things. Is anything else that people can think of? Should we go on to the? So we look at that famous triad of things that took me back to medical school. We got told stasis is the basis, but that might just be.
I did not get told that, but
okay.
I love it.
But it's obviously it's not just stasis. There's three things. It's a triad. Anyway, so vessel wall injury and hypercoagulability, and looking at the Thrombosis UK guidance for COVID, they've kind of helpfully kind of identified where in all of these things COVID might affect. So obviously we do have immobility. If people are kind of very, very unwell, they're going to be immobile anyway. But, if people are kind of self-isolating, especially if they're isolating in their room and they're not feeling well, there's going to be immobility from that sense as well. This is kind of less well known, so that there's this kind of potential for endothelial wall damage because of the virus binding to the ACE2 receptor. That's still a kind of unknown area, but there's certainly hypercoagulability because of the inflammatory response. That's one, and the coagulopathies that are associated. So people are getting DIC as part of a COVID response, and then there's the dehydration, which we're seeing a lot of as well. So there's lots of reasons that people might be at increased risk of thrombosis in COVID. So this is from the guidelines as well. Essentially just follow the kind of NICE guidelines, and you obviously need to be aware of people's renal function if you're going to be starting low molecular weight heparin. Heroin? Oh God, sorry, I'm post-nights too. So speak to your pharmacist if you've got questions about that. And obviously, as we have been thinking with all of our cases, PEs are still going to happen, even whether there's COVID or not. So we still need to be able to think about that as a possible differential diagnosis.
All right. So that's pretty much it for this week's case. Just a couple of reminders that maternal mental illness is a really big cause of maternal death, and so it's really important that we're giving continuous perinatal mental health care regardless of the pandemic. We're recommending that women and healthy babies should be kept together regardless of whether or not mum's got COVID-19. I just wanted to remind you as well that we use a systematic ABCDE approach when assessing patients. I know we all know this. It's just about, I guess, staying calm and cracking on with it while you wait on the crash team to arrive. And a reminder as well that obviously we think a lot about coronavirus at the moment, but it's not always coronavirus. And PAs are a huge risk, as is sepsis in the postpartum period. And it's possible there's a theoretical increased risk if they're COVID positive. And of course, all inpatients should be routinely assessed for VTE risk. At all times really, but particularly in the middle of this pandemic, we need to be really on it with VTE risk assessments and treatment. All right, so we've put some links into some resources, and just again a huge thanks to Dr. Lawn and Dr. Protti for all their input onto this case, and thanks to the MedEd team for all their support in getting this webinar up and running. Cool. All right,
yeah. So we'll hand over.
Yep, there you go.
You guys. Yeah. Sorry. Thanks so much. Again, a really, really useful case, and thank you so much to Cate and Lynsey for putting so much work into all of these cases. I'm sure you'll agree that I've learned so much in the last hour. I learn a lot every week from these guys. Thank you. Please do give us your feedback on what's helpful for you about the cases. Just let us know now, let us know afterwards, let Charmin know. If there's anything you'd like to see, if you want to hear these guys research and present to you, I'm sure they'll be very happy to do that. As is now a bit of a feature, we're going to hand over to Dr. Galuli for a few minutes, just a few words. But again, we look forward to seeing you all next week.
Can you hear me okay, Juliette? Is that coming through?
Yep.
Okay. So thank you again to Cate, Lynsey and the team for bringing together that presentation. It's also one of the highlights of my week, to go back into the clinical kind of a work. I'm not going to spend much time this afternoon, taking up a lot of your time as well. But I thought it really important just to recognise over the last week the number of deaths we're hearing of frontline clinical staff. And we're hearing that nationally on the news, but I thought it was really brought home last week when we heard about the death of a trainee in ELFT, which is quite shocking. And I'm sure some of you had personal knowledge of the but also a consultant, a community paediatrician from ELFT died in this at the same time as well. What we're seeing right across all staff groups at the minute is everybody being touched in some way by the COVID pandemic at the moment, and be that they self-isolating, or they've got symptoms, or they know somebody in their family, or a colleague at work, or a service user, and it's a hugely frightening time. And I just wanted to take the opportunity to say thank you to everybody for all the work they're doing on the front line and all the work that they're carrying out at the moment as well. There's loads of information coming out on a daily basis because things are changing. We've now got the resus guidance locally. I'm aware that the next step, which is in everybody's lips, is the fit testing and how can we get fit tested. Lorraine Sanduza, the chief nurse, is working on this at the moment with the infection control team, because it's not only getting fit tested, but making sure you've got the right FFP3 masks, because you might be fit tested for one, but not fit tested for all. So we have to make sure you've got the right mask, the right fit, and make sure also that not only for resus, but we're identifying all the areas where there's aerosol generating procedures so that people have the appropriate PPE. PPE and its supply is something that never seems to go away, but I'm glad to tell you at the moment our PPE supply is good. It seems to fluctuate from time to time. There was a scare recently about gowns, but the gown supply in London seems okay, and the gown supply in particular to ourselves seems okay. You have to feel safe. It's really important you do feel safe and that you have the appropriate PPE to wear. And I would only encourage you, if you don't feel you have the right PPE to wear, to raise that up through your line management system and your supervisors. That was all I really wanted to say. If you want to, I'll leave it there. Over to you, Juliette.
Well, I guess just while we have Paul, if anyone has any questions for Paul or for these guys as well. Otherwise we can...
I think somebody's put about older BME staff as vulnerable. We're really taking that up at the Trust at the minute. We recognise as an exec that BME staff in particular are having really bad outcomes to COVID, in particular BME men. Why that is, we don't know, but really thinking about how we respond to that is important. And Lorraine Sanduza has the BAME network are having a meeting on Monday, I think, just to discuss some of the issues around about that and how can we kind of address anxieties of our BME staff.
Yeah, thanks for raising, Dave. It's a really, really good point.
Yeah.
Does anyone else have any questions for Paul? Yeah, so questions around VTE.
I think VTEs are for all patients, so you should do them in minimum secure ward as well.
The NICE guideline says that all psychiatric inpatients should be assessed at the time of admission.
Yeah.
And then there's quite a helpful kind of checklist that looks at all of the risk factors and then helps you to make a decision about risks versus benefits.
We can add that link to the slides.
Yeah, and ELFT, it's on the ELFT intranet as well.
Yeah, it may have just been something that's been forgotten, but yeah, the policy is there on the intranet for VTE assessment, so we should be assessing people. But yeah, not just new admissions. People should be, we should be assessing people on the wards.
We should be assessing them as a new admission, but then if the situation changes, so if they become immobile or if you suspect COVID, then that's obviously going to change, and so you'll have to reassess at that point.
I would agree, and if they're moving wards and changing wards in medium security, you sometimes transfer from one ward to another ward. It would be worth doing the VTE assessment at that time as well during the transfer time. Just checking when in general. So it's Omar or somebody wrote a message there about HR have contacted them and asked them to attend for a test for COVID, although they've not been symptomatic for 4 weeks. I would double check what that's about. I don't think you should be going for a test if you've not been symptomatic for 4 weeks and you're at work at the minute. I'm a bit lost in why you've been asked. So there may be a confusion on names or something's coming up that's confused. But I don't see you go, if you've been asymptomatic for 4 weeks, you shouldn't be going for testing.
Any other burning questions for Paul? Okay. That's Omar saying thank you.
Good. And then next they'll get a letter from HR saying, why have you told them that? No, I don't think it should be the case, Omar.
Okay. Well, I think I know the registrars have got a Violent group to get to. I'm not sure. Hopefully, core trainees as well have got some teaching this afternoon. So I guess we can end it.
Yeah.
All right. Well, we'll see you next week, guys.
Thanks so much.
See you next week. Take care.
Look forward to seeing you next week.
Bye.